Hi, everyone. I'm Sona Grigoryan. I'm a pediatric neurologist from Armenia, and today I'm going to talk about epilepsy and its mimics. I want to thank Dr. Burnett, Dr. Stein, and Dr. Necke for this great opportunity. So before I start, let me introduce the contents of my presentation. In the first part, I will be talking about epilepsy and seizures, the definitions, and also the substrate, what generates seizures in our brain. And in the second part, I will be talking about mimics, general approach, of course, and then I will talk in more detail about syncope and migraine. What is a seizure? By definition, it is an abnormal pattern of neuronal activity, and by that we mean excessive synchrony or high frequency of firing. So there is a concept that is worthwhile to talk about. Here we can see that epilepsy is equal to seizures, but seizures are not equal to epilepsy. What I mean by that is that if someone has epilepsy, we understand that they are also having epileptic seizures. It's understandable. But if someone is having epileptic seizures, it does not necessarily mean that the patient has epilepsy also. So how is that possible? To clarify that, let's talk about the definition of epilepsy. Epilepsy is a disorder of the brain that is characterized by an enduring predisposition to generate epileptic seizures. And the key here is the enduring predisposition. So there must be some long-lasting alteration in the brain that makes it prone to generate seizures. Let's discuss a few examples. Here is a list of conditions where there is a seizure and yet the patient is not diagnosed with epilepsy. For example, a boy falls, hits his head, and on the way to the hospital starts having seizures. Apparently, we're not going to diagnose him as having epilepsy. Or a patient develops seizure shortly after an alcohol withdrawal. The key here that any seizure that we are witnessing develop in close temporal relationship to the assault. So these are acute symptomatic seizures, which occur at the time of a systemic insult, such as hypoglycemia, hypocalcemia, or in close temporal association with certain brain insult. This means that if a certain time has passed from an insult to the brain, the seizures will not be considered acute. And every assault has a particular allowed time frame during which an acute seizure can occur. Going back to our list of acute seizures, we can see a few of such time frames. For example, say 7 days for traumatic brain injury and cerebrovascular disease. 7 or to 48 hours for alcohol withdrawal, etc. Coming back to the definition of epilepsy. In the previous slide, we gave the conceptual definition of epilepsy. Now we will define it in such a way that we will help the physician answer the question if the patient he is diagnosing actually has epilepsy or not. So first, at least 2 unprovoked seizures occurring more than 24 hours apart. This does show the propensity of the brain to generate more seizures in the future. And in fact, researchers found that the chance of having further seizures after 2 unprovoked is minimum 60%. I will come back to this later. Moving forward, we do not always wait for the second seizure to occur to diagnose an epilepsy. And here comes the second definition, which reads 1 unprovoked seizure and a probability of further seizures similar to the general recurrence risk, this previous 60%, after 2 unprovoked seizures occurring over the next 10 years. So an example would be someone with brain trauma more than 7 days ago developing a seizure, why I'm mentioning these 7 days, because if it was in 7 days, we would say that this is an acute symptomatic seizure and it would not mean anything. But if the seizure develops after the 7 days of having a traumatic brain injury, then we realize that some change occurred to the brain. So the brain has this predisposition to generate further seizures. And the third example, and the third example would be diagnosis of epilepsy syndrome. So imagine that a boy comes in and that boy has, I don't know, parents report that the patient was unresponsive during that day. So we realize that we are still in this 24-hour time frame, but we think that the boy might be having absent seizures. And when we are starting to, when we are asking the patient to hyperventilate during the EEG monitoring, the child becomes unresponsive. We see this spike and wave discharges, and it's understandable that the patient probably has the childhood absence epilepsy because he's in the appropriate time, age, 10-year-old boy, and the clinical manifestations are appropriate. So to diagnose epilepsy in that kid, we are not going to wait for another seizure. And here we have a diagnosis of epilepsy. So it is also important to address where the seizures are generated. For example, in trigeminal neuralgia, as we can see here, we can have this excessive synchrony in the trigeminal ganglion or the fifth cranial nerve, but we do not consider this as an epileptic seizure. One good example would be hypothalamic hamartoma that is generating gelastic seizures. These bright areas that we can see here show the hyperperfusion areas, and we can see that there is no involvement of cerebral cortex. So this is a very good example that there's no need for involvement of cortical neurons in order some seizure to be considered to be epileptic. So answering the question of where, from network perspective, seizures could arise in neocortical, thalamocortical, and limbic and brainstem networks. So how do we approach a patient that is presenting with paroxysmal events? First, of course, we need to answer the question if the episode that the patient is having is indeed a genuine epileptic seizure, or if this is an epilepsy imitator. And we must realize that the imitators are many. And then, after establishing the epileptic nature of the event, we will classify this into a seizure type according to International League Against Epilepsy. So when classifying, we are interested in the seizure onset because this seizure onset might help in establishing the diagnosis and in treating the patient appropriately. For example, if it's focal onset and the onset in temporal lobe, we might remove simply this region that is epileptogenic. And also we are interested in the consciousness levels of the patient anytime during the seizure, because this might have implications in patients' everyday activities. So here we can see the International League Against Epilepsy classification of seizures. This is the basic version. So we can see that we classify according to onset. It can be focal, generalized, or unknown onset. And here is the expanded version of the classification. And here we can appreciate how diverse seizure manifestations can be, from dramatic generalized tonic-clonic seizures to more subtle sensory seizures that are not apparent by the bystander. Okay, moving forward to the mimics. Here's a list of some epilepsy imitators. They are paroxysmal events. Many of them also have altered consciousness, such as syncope, behavioral changes. For example, there are some panic attacks or non-epileptic events. Also, there can be a motor component, for example, the intermittent movement disorders. And how do we approach this patient that is having a paroxysmal event? Because we see they are rather numerous. So history plays an important role. Here we can see the questions that we should ask, and please also pay attention to the sequence of the questions. So we first ask about the setting for precipitating factors, then the prodrome, and onwards until the nature of recovery. So setting of precipitating factors is of paramount importance, as there might be some triggers, and usually they are not typical for epileptic seizures. So if someone says that some peculiar trigger causes them to have the fit, we usually think that this should not be an epileptic seizure. Of course, there are some reflex epileptic seizures, and an example would be a photoparoxysmal seizures generated by flashing lights. But usually a trigger is not a typical thing for an epileptic fit. Regarding the precipitating factors, for example, a loss of consciousness with head position, might be a result of sudden change in intracranial pressure. For example, this can be due to Chiari malformation. Moving onwards, the prodrome. The prodrome is another indispensable part of history taking. And as an example, perioral and digital numbness can be due to hyperventilation spells. Regarding the time course, seizures do not last long, usually up several minutes. But the problem here is that, usually other non-epileptic paroxysmal events, they also do not last too long. For example, syncope. So this might not be very informative. Regarding the behavior, stereotypy. The stereotypy is really very helpful because epileptic seizures, no matter how they are manifesting, from one seizure to another, they do not change. And this really helps because, for example, in psychogenic spells, there might not be such a dramatic stereotypy as we have in epileptic seizures. Behavior during the episode might not be very helpful because actually epileptic seizures can have very variable manifestations. But in terms of behavior, one thing can be helpful. For example, if the patient is resisting the eye opening, this might point to psychogenic non-epileptic attack. Apparently, a patient that is having a generalized tonic-clonic seizure, he will have eyes open and he will not resist the eye opening. Ameliorating factors also are helpful. For example, if patient is having syncopal attacks, maybe he would lie down and the attack will be aborted. And of course, nature of recovery. Usually patients that are having generalized tonic-clonic seizures, they do not recover immediately. So this is also helpful. Okay, moving forward, let's talk about syncope. And here's the definition of syncope. It's a symptom that presents with an abrupt, transient, and complete loss of consciousness associated with an ability to maintain postural tone with rapid and spontaneous recovery. The definition here is really very important. And also, the presumed mechanism is cerebral hypoperfusion. So as we're talking about the cerebral hypoperfusion as the culprit of the syncope, let's see what maintains our normal cerebral perfusion. Of course, we need to have an adequate stroke volume, heart rate, and total peripheral resistance, because otherwise blood will, if total peripheral resistance is not adequate, blood will run away into other body parts and brain will be deprived of blood. And resistance of cerebral vessels is also important, because if the resistance is too high, there's no way that enough blood will enter those vessels. So let's spend some time on explaining the orthostatic reactions. Let's call in the guy from the previous slide and have him lie down, then stand up. And what happens is the blood will pool in the vessels of legs due to gravity, and this will lead to decreased venous return. Heart will pump less blood into arteries, and this will sense our baroreceptors. So as our baroreceptors will sense this drop in BP, they will activate our vagal tone, our sympathetic tone, which will lead to vasoconstriction, and they will inhibit the vagal tone so that we are not going to have bradycardia. Okay. So causes of syncope are reflex-mediated orthostatic hypotension and cardiac syncope. Let's address them one by one. So in reflex-mediated syncope, as the name implies, there is some reflex involved in the type of syncope, and to better understand it and not to confuse it with other types of syncope, let's recall that a reflex has its afferent limb and its afferent limb. In this case, the afferent limb causes the vagal tone to increase. Can you see this? I don't know, this part. Okay. So this can lead to increase to vagal tone and sympathetic decrease. As a result, of course, we will lose the constriction of the vessels and a bradycardia can develop. Paradoxical is orthostatic vasovagal syncope, which happens usually after a prolonged standing. Why is it? It is paradoxical because the opposite of what we know develops, because after a prolonged standing, we should increase the sympathetic tone and decrease the vagal tone. As we can see in orthostatic vasovagal syncope, the opposite occurs. Another type of vasovagal syncope is emotional vasovagal syncope, and it is caused by fear, pain, and medical procedure, etc. So in situational reflex-mediated syncope, we are somehow stimulating our vagal nerve, and this can be by micturition, defecation, etc. In carotid sinus syndrome, carotid sinus is oversensitive, and as a result, anytime it receives pressure, it sends information to our brain centers to decrease sympathetic tone and increase vagal tone. Hence, syncope develops. And it is common in elderly who have atherosclerotic changes in their carotid arteries. Okay, moving forward, there's also orthostatic hypotension. And in this case, the reflexes are not faulty. They are simply not enough, which means that there is not enough adrenaline released due to autonomic failure. Here we can see it. Or not enough vessel constriction due to drug effects, for example, a patient is receiving vasodilators. And of course, the cardiac syncope, we must not forget that our pump, our heart, it must function normally in order enough blood to get to the brain. So as there is misconception that syncope happens in upright position, let's stress that cardiogenic syncope can happen in recumbent position. Also, there might not be the typical aura of lightheadedness and graying in front of the eyes as seen in vasovagal syncope, which might erroneously lead to epilepsy diagnosis. And history of episodes associated with exertion is helpful. So let's see what happens to brain waves during cerebral hypoperfusion. Here you can see a patient's EEG on whom a head tilt test was performed. Here we can see that the patient is maintained in upright position, and vasodepressor syncope means that the patient develops low blood pressure, but the heart rate does not change considerably, as we can see in this trace. And we can see that the patient develops syncope, and at the same time, we can see that the frequency of the brain waves decreases, and on the opposite, amplitude of the brain waves increases. So we have these theta range waves, and then we have the delta range waves. When we return the patient to a recumbent position, the brain waves return in the reverse position. So first, theta frequency will reappear, and then when the patient recovers consciousness, normal brain waves are there. The same thing will be seen in cardioinhibitory vasovagal syncope, with the difference that we can see that even an isoelectric line is developing. So due to the hypoxia, cortical neurons are turned off literally. And only after the patient returns to recumbent position and blood re-enters the brain, we can see that the cerebral activity is returned to normal. Okay, so I would like you to note that during these episodes of syncope, there were no epileptic discharges. So at the same time, note also that some patients that have had similar EEGs developed myoclonic movements or tonic movements. So we can exclude that these movements are of epileptic origin. So what we are witnessing instead, it's called syncopal myoclonus. And the origin of syncopal myoclonus has not been definitely established. And nevertheless, we think that the reticular formation of medulla plays a great role in initiating these myoclonus. And we can see here that and every time we have hypoxia, cortical neurons shut down, and as a result, the reticular formation becomes disinhibited, and they start to generate these myoclonus. So in fact, having the myoclonic movements during syncope is not that uncommon. So apart from tonic and myoclonic convulsions, which can be confusing and might be interpreted as epileptic, patients with syncope might have automatisms. For example, they might have this writing posture. They fall down, and without regaining consciousness, they try to wake up again. They might have also, they might have as an automatism fumbling, etc. Also, they might have vocalizations. They might have eye deviations and hallucinations. So this might erroneously lead to think that this episode was an epilepsy, but what we must be aware of is the nature of different symptoms. For example, in myoclonic jerks, they were usually multifocal and non-rhythmic. or multifocal and superimposed on generalized myoclonus. This is in contrast to generalized tonic-clonic seizures, which are rhythmic. Regarding the eye movements, downbeat nystagmus is pretty typical for syncope. It's just really hard to detect it. On the other hand, upward deviation of the eyes, this is not a good sign to tell apart syncope from epileptic seizures, because actually in generalized tonic-clonic seizures, we can also document this upward movement of the eyes. So, of course, we realize that no specific sign definitely confirms epilepsy or syncope. For example, someone can bite his tongue and it will not tell that this is definitely a seizure and not a syncope. Nevertheless, there are signs more indicative of syncope and signs more indicative of epileptic seizures. Here's a paper by Shelton at ALIA. They developed some questions that were given scores, plus for seizure favoring signs and minus for syncope favoring signs. So here you can see this. And if the sum of the score were less than 1, the diagnosis was syncope. If 1 or more, then the diagnosis was seizures. For example, we can see the scores with plus sign. For example, the tongue biting favors more the diagnosis of seizures. On the other hand, the lightheadedness favors more the syncope. Okay. So the approach to the patient with syncope is, of course, history and physical examination. And don't forget about the ECG, as the cardiac causes are not uncommon. The history should emphasize the phenomena of the events, because we need to understand how the myoclonus appeared, because simply stating that the patient was shaking doesn't mean that the patient had a seizure. The frequency of events, the precipitating factors, etc. And of course, the physical exam should emphasize the cardiac exam and evaluation for orthostatic hypotension. So regarding the ECG, proper ECG should be obtained because there are cases where patients with cardiac syncope were diagnosed with epilepsy. And it is recommended to do an ECG because this might prevent potentially fatal outcomes. So moving on to migraine. Here we can see the different types of migraine. And usually there is no difficulties diagnosing migraine without aura or migraine with the typical visual aura. Ones that are more frequently confused with epileptic seizures are a migraine with brainstem aura, which by the way can have consciousness impairment, and hemiplegic migraine. Oftentimes, patients with hemiplegic migraine are confused with people who have seizure and then develop thought paralysis. But today I will not talk about the hemiplegic migraine. Okay, so as I said, migraine with typical visual aura is usually not confused with a seizure, but the opposite can happen. So a patient with occipital lobe seizure might be misdiagnosed with migraine. Why? Because patient comes in, he says that I see something, I have visual hallucinations, and then I develop headache. We must be aware that any postictal headache is rather common in patients with different types of seizures. So we need to pay attention what type of visual hallucinations they are developing. And here we can see more typical visual hallucinations for patients with occipital lobe epilepsy seizures. And here we can see a more typical visual hallucination for people with migraine. So people with occipital lobe epilepsy usually have these circles and they are multicolored. Usually they appear in the temporal hemifield and they have the tendency to go towards the center. And in case of migraine, these hallucinations can appear anywhere, not necessarily in the hemifield of the temporal part. And let's have a look. So we can see here how a scotoma, this gray scotoma, develops in the center of visual field. Then it starts to grow Of course, there is some oscillation in the periphery, which is colorful, but we can definitely tell this apart from the visual hallucinations of occipital seizures. So you can see how this grows bigger and bigger. So, okay, fine. I think that's enough. So also we must pay attention to the time course of the visual hallucinations. Brief, less than 1 minute, elementary visual hallucinations that develop rapidly within seconds. This is more typical, of course, for occipital seizures and not for migraine, because migraine is for 5 minutes or more. This is the typical course. So now coming to the migraine with brainstem aura. Migraine with brainstem aura, we can see here how it can be manifested. These are all brainstem signs: dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, and of course, decreased level of consciousness. This is usually the main reason why migraine with brainstem aura might be confused with epileptic seizure. And of course, no motor or retinal symptoms. So migraine with brainstem aura, how we diagnose it. The diagnosis is clinical. It's based on history, on physical exam, and fulfillment of the diagnostic criteria. I will not stop on it too long. And also, we need to emphasize that there are no diagnostic tests specific for migraine with brainstem aura. So here are the criteria. There's interesting, for example, how the EEG changes during the migraine with brainstem aura. And actually what people find is usually a slowing of EEG activity. And mostly this slowing predominates in the occipital parts. So usually you can do an EEG and not find any epileptic activity during the attack. Also, as we can see, there's an acute therapy for this type of migraine, and it does not differ from the typical migraine therapy. And that's interesting that maybe a patient who is having these manifestations, we might offer them to maybe use a medication early in the course, for example, an NSAIDs. And if this non-steroidal anti-inflammatory drug aborts the attack, this will favor the diagnosis of migraine with brainstem aura. And that's all for today. Thank you. Let me know if you have questions.